Right. So what are the symptoms of Benedict's syndrome? As all of you know that Benedict's basically involves that part of the midbrain where the red nucleus is associated. That's the reason we get a rubral tremor, and the patient will have a pupillary dilatation, cerebellar dystaxia, the intention tremor. Why cerebellar dystaxia and intention tremor? There is a dentato-rubro-thalamo-cerebro pathway which connects the cerebellum with the dentate nucleus with the red nucleus and ultimately to the cerebral cortex. That's the reason cerebellum being a important area that controls our posture, there is a postural instability and a rubral tremor in the case of the Benedict syndrome is what you need to remember. What is true about the embryology of the stomach? I think this question you answered, most of you. What is your answer? Mohan, please give mic to front row. Today we are missing Nafiz, last week. So a lot of our students across country are very happy that it is an interactive discussion where students are pronouncing their answers. You can give another mic. You gave the front row one mic. Yeah, Fatima and the group, please give your possible answers. No problem. Array, feel you give on to our Venkatesh is there. I am very happy. Please make him the chairman of the session. So please give him another mic. That's good. Right. So it is the 90 degrees clockwise rotation around the longitudinal axis. The primitive stomach will be rotating is what you need to remember. So who mediates the postural reflexes, doctor? There are two important extrapyramidal tracts, medial and lateral vestibulospinal tract. Lateral vestibulospinal tract arises from the lateral vestibular nucleus. What is its function, doctor? It basically will mediate the excitation of the extensor motor neurons is what you need to remember. Medial vestibulospinal tract basically mediates the postural reflexes of the head and neck. See, you have one corticospinal tract. What is the other name given for the tract? Pyramidal tract. Whereas 4 tracts are called extrapyramidal tracts. What are they? Vestibulospinal, rubrospinal, tectospinal, reticulospinal. These 4 tracts are called extrapyramidal. Spasticity is a feature of corticospinal tract lesion, pyramidal tract. Babinski positivity is a feature of corticospinal tract, pyramidal tract lesion. Whereas rigidity is a feature of extrapyramidal lesions is what you need to basically remember. Now doctor, what leads to the increase in intracranial tension except, who like to propose an answer? Venkatesh, what is the answer? Possible answer?
Decrease in PSCO2.
Decrease in PSCO2, beautiful. It is an increase in PSCO2, hypercarbia that lead to development of raised acid. That's the reason you will see neurosurgical wards. Neurosurgical wards. Our speaker is here. Please pass on the mic. Nafiz, what is your name, doctor? Nafiz is as powerful as Nazma Heptullah. So please, because a lot of students online, they gave a very good feedback. If students are also interacting, we are buying few more mics so that when 200 students are attending, at least we should have 30-40 mics. So that's good. Most common acid base disturbance in mechanical ventilation. What is your answer? Generally, what is the mistake done in ventilator? As a enthusiastic house surgeon, you want to keep the rate very high, but high respiratory rate leads to alkalosis. Is the mic on? Just make the mic on. Yeah, respiratory alkalosis. Very good. Sodium glucose cotransport. What is your answer?
Secondary action.
Question number 8. What do you like to propose, doctor? Arundhati is proposing passive transport. What are the alternative answers? Please punch along with the question number, the answer. That makes it easier, online classmates. Yeah, what is your answer? Question number 8. Shravan and Mamta are thinking secondary active transport.
Secondary active.
Very good. Secondary active transport. So what is the driving force for the absorption of the glucose, doctor? It is the sodium which will move and creates an electrochemical gradient. That is the driving force for the movement of the glucose. That is the meaning of secondary active transport. Our classmates study and we get the seat in MD. That is called secondary active transport. Now, phantom limb phenomena. What is the meaning of that?
Law of projection.
Huh?
Law of projection.
Projection.
Even if your girlfriend dumped you, you still feel that she is there on your side. Is called phantom limb phenomena. So amputated limb if you do, even if you do amputation also, you will start feeling the pain, touch everything as such that limb existed. This is called as phantom limb. Why does this happen basically? If you take the sensory cortex, our entire body is mapped. The thumb sensations are reported in a special location in the brain called thumb. Our little finger sensations are stored in a different location called little finger in sensory cortex. Even if you remove little finger also, you didn't remove the location in the brain, no? So anywhere in the path until little finger it gets stimulated, you will get a feeling as such your little finger is being touched. That is called law of projection. Now, muscle contraction in response to the maintained stretch is initiated by whom? Very, very specific question. You answered this means you don't read physiology until exam. It's my, I vouch that guarantee for you. Yeah. What is your answer, doctor? Fatima proposes tendon organ, Golgi tendon organ. Nafiz?
I wrote it back, sir.
Huh?
A.
Nuclear bag is answer. Venkatesh?
Tendon organ.
Golgi tendon organ is Venkatesh answer. Any answer? Come on, it's a platform for discussion and fighting and arguing. I am seeing one C, Ramakrishna is proposing A. Question number 10, Shravan is proposing C. Lot of people thought it as Golgi tendon organ, even online also. No worry. Lot of our classmates are wrong, we are wrong. Time to celebrate. So, nuclear bag, nuclear chain. You should be very clear, doctor. One page in Ganong's textbook. Definitely one question will be asked on Golgi tendon organ, nuclear bag, nuclear chain, alpha afferents, gamma motor neuron, etc., etc. I leave to you the list of high yield topics. I hope you are all taking that booklet of high yield topic list, 1139 topics. Just to read the top 30 topics, that's enough if you don't have time. In every subject we have given 60 topics, but you can even go through 50% of those topics also, you will get seat, that's my word. Now the question comes, sir, how do you know that these are the high yield topics? Is a obvious question, right? I don't fake that we are the part of examination body, but one thing I like to definitely tell. Every year All India MD entrance 300 questions. Past 15 years is 5000 questions. Similarly, there are 5000 in the past 15 years of AIMS and PGI. Totally 18,000 questions we analyzed. Every question we labeled which topic it belongs to. And then asked the computer Mahashay, please bring all questions belonging to a topic to one place and give us the number of times that question has been asked, the topic has been asked, and arrange it in a descending order. Computer is a slave. So it then arranged it in a descending order. So that's how we reached a conclusion, what are the first things to do first among the topic list. For example, you are all having that booklet with you. Open the gynecology obstetrics. Gynecology obstetrics. Highest number of topics, from where did they ask, doctor? Which topic? Huh? Contraception. Without reading contraception, reading Shah and underlining it is shame. Doing mistake in contraception is a noteless suicide. Let me tell you. So when we open Shah's textbook, all our eagerness in the reading room is read female genital tract and know where is the Bartholin duct, where is the etc., energy is over. Honeymoon phase with gynecology is over. So what will you do? To read the remaining pages of Shah is boring. Instead, you start with first contraception, then cervical carcinoma, then ovarian carcinoma, then go to endometrial carcinoma. You reach at least the top 30 topics as given to you in the high yield topic booklet. We will also send it to all our other center students also. That's enough. So similarly in physiology, what is the most important thing that you need to read first when you open physiology textbook? Physiology is a big forest. Nephron physiology is what you need to read. What is collecting duct, what is macula densa, what is juxtaglomerular apparatus. Number 2, second high yield is hypoxia, different types of hypoxia, alveolar arterial oxygen difference. What is meant by hypoxic hypoxia, histotoxic hypoxia, which will respond to oxygen, which will does not respond to oxygen, everything you should read. Top 30 topics you read and go doctor in that list which I have given to you, you will smash the examiner. Let me vouch you. Now, nuclear chain fibers is a slowly adapting receptor. It detects the absolute length is what you need to remember. Wow, this is a beautiful question. Whoever has, for online students will put up that list in the Edmodo, you can download the online students. Yeah. What is your answer? Skeletal muscle, PFK2. PFK1, do you know there are 2 PFKs existent in the regulation of the glycolysis? You should know. What is your answer? Venkatesh, what is your golden answer? A, that's good. See doctor, this is very important. PFK2 will convert fructose 6-phosphate into fructose 2,6-biphosphate. Fructose 2,6-biphosphate stimulates the PFK1, which converts fructose 6-phosphate into 1,6-biphosphate and drag the cycle towards glycolysis. Whenever there is an increased demand for glycolysis, how will the body will know? By increased activation of the PFK2 is what you have to fundamentally appreciate, doctor. One dirty question on electron transport chain. I always used to hate it as an entrance preparing aspirant. Which inhibitors for which complex? Ultimately when you join PGH Chandigarh, you need to know where is hematology complex, where is pediatric complex. But to reach those complexes, you need to finish this complex. So what's your answer? D. One strong answer.
D.
Nafis, what is your wrong answer?
D.
Is it in on mode?
Yes,
Yeah.
sir.
C?
D.
C for cat.
D.
D for
Malate
malate to CoQ. What is your proposal, Venkatesh? Anybody else? Huh? Anybody else? Excellent. Malate to CoQ. That is the place where NADH is basically exhausted and complex 1 basically accepts the electrons from the NADH and transfers them to coenzyme Q is what you need to remember, and malate dehydrogenase will convert malate to oxalate generating NADH in this process. Now fasting hypoglycemia, if you are little late for the lunch by 2 hours or 3 hours, you will start getting that hypoglycemic jitters. There are few people who can eat a chocolate and do 36 hours night duty also, only on a chocolate. There are few people, right time, right food doesn't enter into mouth, they will be collapsing on the floor among our classmates. So what is your answer? You like to propose?
C.
C? Venkatesh says C. Nafis?
I wrote it A, sir.
You wrote it as A. Any other answer? Question number 13. Online students, please punch your answer. Tara is proposing PFK1. It is adenylate cyclase. See doctor, glycogenolysis, glycogen synthesis and regulation. favorite high yield topic for entrance. If the adenylate cyclase is defective, the glucagon cannot initiate the glycogenolysis. Glucagon also lead to inhibition of glycolysis in the liver. What is the main purpose of glucagon? To increase blood glucose. For that what should happen? Glycogen should break down and glucose should not be broken down into pyruvate. Glycolysis should be inhibited, glycogenolysis should be stimulated when you have glucagon. How will glucagon mediate that? Using the adenylate cyclase, it lead to cyclic AMP, which in turn will lead to phosphorylase kinase activation, which lead to glycogen phosphorylase activation, leading to the glycogenolysis. Then that lead to development of fasting hypoglycemia. I leave to you the literature. What is the difference between alpha receptor and beta receptor of epinephrine? Alpha receptor of epinephrine will initiate calcium pathway, whereas beta receptor will, just like glucagon, will act on adenylate cyclase. Beta receptor stimulation lead to glycogenolysis. That is what you need to differentiate. Now doctor, there is a inactivating mutation that led to unregulated muscle fatty acid oxidation. Typically that inactivated protein would have been which enzyme? Otherwise, which enzyme's end product has a capability of controlling the fatty acid oxidation? Simple way of asking. You must know positive and negative allosteric activators and inactivators of fatty acid oxidation, beta oxidation. So this is the question based on that. Venkatesh, you are completely clean bowled in biochemistry, especially these issues. Any other alternative answer? Just some guesswork, doctor, no problem. Okay, difficult to guess in such things. But Fatima rightly guessed, please give a big clap, doctor. Big clap. D. Why? Acetate, I am not listening. Fatima's answer is D. So doctor, acetyl-CoA carboxylase, what it will do? It will convert acetyl-CoA into malonyl-CoA. You all know malonyl-CoA has an ability to regulate fatty acid oxidation. How? See doctor, what is the end product of fatty acid oxidation? Acetyl-CoA. So if lot of acetyl-CoA is there already, do you need fatty acid oxidation? No. How will the body know that there is already lot of acetyl-CoA? All that acetyl-CoA converts into malonyl-CoA. Abundance of malonyl-CoA will be sensed by the acetyl-CoA carboxylase, I mean the beta oxidation enzymes, that sufficient amount of acetyl-CoA is already there, there is no further beta oxidation, and that inhibits the beta oxidation. So that is what you need to appreciate. Ribose 5-phosphate to glucose 6-phosphate. What is the obligatory intermediate in this conversion? You like to say? Xylulose 5-phosphate is the popular answer, which is correct answer. There are two wings in pentose phosphate pathway. One wing is oxidative, other is non-oxidative. Between the two, which is reversible and which is not, doctor? Non-oxidative is reversible, oxidative is not reversible reaction. So you must know what are the different things involved in the non-oxidative phase. In non-oxidative phase, ribose 5-phosphate gets converted into glucose 6-phosphate and it is a reversible phase, is what you need to basically remember. Now, what is wrong about HIV? Very fundamental question. Give your guesswork. Here you can guess. B. A low CD4 count, you mean predicts? Predicts? I will show you 70 or 80 CD4 count guys also contesting for the member of parliament. and happily brimming and participating in athletics. It is not a predictor, unlike a lot of people think that it is a predictor. No, it is not a predictor for the progression. Any other alternative answer, which is a possibly true statement?
A.
High viral load. High viral load. You mean to say high viral load is there means is it a predictor or not predictor? It is also not a predictor of response. It is not that high viral load guy has a better predictor, better responsive. Low viral load means non-responsive. ऐसा कुछ है क्या theory? नहीं है. I know most of you will answer wrong. Next, C. Ramakrishna. I know correct answer comes last. That is a Murphy's law. A low CD4 does indicate an increased chance of opportunistic infection. Yes, but not progression to AIDS. Option 4 is wrong. What is pneumococcal pneumonia? Capsulated organism. For that, humoral immunity is important or cell-mediated immunity? Humoral immunity is important. Is that impaired in retroviral? No. So that is the reason there is no increased proclivity to the pneumococcal pneumonia, is what you have to basically remember. Okay, doctor? What is wrong about interferon? But for our earlier question, Viz was right. He said D. Yeah. What is your answer? Interferon. I am not getting some splashing answers. Venkat, commit.
C.
C. You mean to say new viruses are not assembled after in the interferon protected cells. That is how interferon will act. Alternative answer. Ramakrishna thinks interferon causes production of second protein that alters protein synthesis. It directly doesn't. True. Nafis?
C.
Even Nafis thinks truth and truth alone. That's good. It does not stimulate any inflammatory mediators, interferon. There is a difference between it and interleukins. Interferon only makes other cells from getting infected with the virus.
Sir, interferon gamma will increase production of IL2 and IL4. IL2 no sir.
The viral induced interferons do not have any ability to produce cytokines directly. That is the main. They don't initiate any inflammatory reaction. PML is basically caused by polyoma because progressive multifocal leukoencephalopathy is caused by JC virus, which is a polyoma. Listeria. What is your answer? Come on, sing along the answer.
A.
A, that's good. It is both, it will multiply both extra and intracellularly, is what we need to appreciate. Legionnaires. What is rapid test, what is sensitive test, what is specific test? Three things are there to know. Bolo. Legionella. Cold agglutinin. Most unused test. Any other? A. Nafis, what is your answer?
A.
A. That's good. Specific antigen in the urine or respiratory secretions? Urine also will do, that is specific. But most rapid is in the respiratory secretions. That's what you need to appreciate. But it is non-specific. Huh? Yeah, in the explanation it is given. Legionella in the urine is most sensitive, but not most rapid. In respiratory secretions, it is much more rapid to detect. E. coli O157, how does it basically act?
C.
Shiga-like toxin, beautiful. GDCS mein what is not a first line?
C.
Carbamazepine. Valproate is first line, not carbamazepine, which is a second line, which is not P450 inducer. What is your answer?
B.
Huh? You thought?
B. Acute alcohol.
Acute alcohol, very good. You must know between acute alcohol and chronic alcohol, which is inducer, which is inhibitor. There is a difference between the two. Enoxaparin versus heparin, what is the answer?
D.
You like to say inhibits synthesis of clotting factors more effectively, enoxaparin?
D. Doesn't cause thrombocytopenia. Doesn't cause HIT.
Huh?
Doesn't cause HIT syndrome.
You mean enoxaparin doesn't cause HIT syndrome? Heparin induces thrombocytopenia. Direct thrombin inhibitors do not cause HIT syndrome. Like argobatran, what is that? You have a couple of drugs which are direct thrombin inhibitors.
Lepirudin.
Huh. Teacher is slowly entering into presenile dementia, so you may be remembering better. Direct thrombin inhibitors. Otherwise, any other heparin ka natural nature. Any dog you take, it will be loyal. Any man you take, he is highly infidel. So there are certain jatika trait. So also is heparin, any heparin. So doctor, half-life they differ. Neurogenic and nephrogenic diabetes insipidus, how do you differentiate?
Desmopressin.
Super. Which will respond, which will not? Nephrogenic?
Neurogenic will respond, nephro won't.
Excellent. But one favorite question examiner is going to ask you in the tomorrow's MD entrance. Only you are going to answer, nobody else in the world. What is that? You can use thiazides for any kind of nephrogenic diabetes insipidus. But examiner is going to ask you a question. Lithium induced nephrogenic diabetes insipidus.
Amiloride.
Amiloride. Right? Now, what is that antineoplastic drug?
Bleomycin.
Bleomycin. So?
G2 phase. G2.
G2. That's good. G2 phase of the cell cycle, it acts mainly. Unstable angina. Give me an answer, doctor. Acute coronary syndrome.
Abciximab.
Huh?
Abciximab.
That's right. Abciximab is a 2B3A receptor monoclonal antibody. Now, good pasture.
Type 2.
Type 2, which is cytotoxic. What suppresses the response of lymphocytes?
TGF beta.
TNF alpha and
TGF.
IL-10.
Huh? TNF?
TNF alpha and IL-10.
TGF beta.
TGF beta.
It's a repeat question, yeah. Earlier also I think we asked the same question. Fragile X, Huntington's chorea. I think 4 to 5 questions by mistake pathology got repeated from the recent exam. Okay, so we'll leave the pathology. Already we finished this in the previous exam, by mistake it got repeated. Now let us be the snake charmers for the MD entrance. This question is there in your paper? Cobra venum is?
Neurotoxic.
Naja is neurotoxic. Then fornication is a feature of? Cocaine. So all these things, like a parrot in the exam, you should remember, doctor. Chromium, cancer lung, cocaine, black tongue, opium, rhinorrhea, zinc, metal fume fever, mercury erythism, arsenic, cholera like diarrhea. This is the checklist before the aeroplane called MD preparation takes off. Futuristic attitude.
Burns.
When high temperature like burns is involved. What is species specific?
Presbytin.
Presbytin, excellent. Earliest sign of pregnancy?
D.
Beta HCG or amenorrhea?
D. Beta HCG. It is demonstrated within 9 days of loss of cycle.
Actually, this is a idiotic question, the way it is framed. We can leave that. Yeah. What is histogram?
Quantitative.
You mean to say quantitative?
A.
A. Quantitative.
I think there is a dual answer in this.
Yes, sir. Dual answer.
Dual answer is this, sorry for that. So it's a nominal scale, and also then what is the central value of around 180 values?
Second tertiary.
Second quartile will divide the data into 50:50. Z score 15 because it is one standard deviation away from the mean value. TB not affected by current control measures.
A.
Annual risk of infection.
Sir,
How many yeah?
prevalence, sir?
Huh?
Prevalence of infection won't decrease, no, sir.
Prevalence of?
Prevalence of infection won't decrease, no, sir, with the treatment.
If you do good control measure, you will make the new cases convert into old cases. So that will change the prevalence, right?
Prevalence
But
of disease will decrease, but prevalence of infection won't decrease, no, sir.
prevalence of infection will change, increase in fact, because if you don't cure and you only treat, then new cases become old cases, and that will increase the total number of cases. So that's the reason it is affected very much. Positive sputum smear. How many organisms?
10,000.
10,000.
10,000.
Huh?
10,000.
Previous question. Yeah. Please pass on the this thing. Good. Now I enjoy the discussion. Bolo.
Yeah. Current control measures do not treat multi-drug resistance, no, sir. So
Current control measures. Yeah.
they do not treat multi-drug resistance, no, sir.
The question is, what is the best indicator which is unaffected by the current control measures? We are not asking, see, the number of multi-drug resistance cases, if you take them percentage,
It is also
will
not
it reflect
unaffected.
anything about the current control measures?
That's what, sir. That is why it is not affected by current control
No,
measures.
it should
sir.
reflect current control measures, but it should be, it should reflect the trend of TB, and at the same time it should be unaffected by the current control measures.
Sir, current control also includes treatment for MDR-TB, no, sir.
Current control measures need not. Current control measures,
Also includes treatment of MDR-TB, no, sir.
control is different from treatment, no? Huh? So, if the incidence, annual risk of infection, which is unaffected by the current control measures, prevalence is affected, everything else is affected, that's the point. Huh? Now, how many days you will wait for residual paralysis?
60.
Whoever holds mic has to tell
60.
answer. Yeah. What's the answer?
60.
60 days.
60. Beautiful. And control of blindness?
C.
6 by 60, less than 6 by 60. Then first choice to know a unknown or a new disease.
For rare diseases, it is case control, no, sir.
So what is the answer?
I wrote it B, sir.
Huh?
I wrote it B.
But case control is mainly to unknown or a new disease, but
Rare
it is
disease.
for the rare disease, that's right. And also it is to test the hypothesis, not to propose a hypothesis. First you need to propose an etiological hypothesis for an unknown disease. For that, what do you need to do? You need to describe the disease. That's the reason it is descriptive epidemiology.
46 is skipped, sir.
46, okay, you want to fight on 46. What is the answer?
C.
See,
That's what? 46 was also there, okay. It is not 100%, how much coverage?
9 months to 5 years it is, not 3 years.
No, it is still 5 years only, but it is 75%. Whatever it is, you are ultimately right in answering C, that's good. Now, एक क्वेश्चन तो कलर कोडिंग के ऊपर होना ही पड़ता, बोलो What is the answer? What is your favorite color this week?
Yellow.
Yellow.
Yellow, that's good. Then post disaster,
Gastroenteritis.
I wrote it wrong.
post disaster, what is the answer, doctor? Gastroenteritis is not. I mean, gastroenteritis is the common reported disorder. Factory workers ko why do you frequently examine?
For appearance of symptoms.
Secondary prevention.
That is secondary prevention.
So that early diagnosis and treatment you can do, so that you will have more people to work for you in a healthy way. So secondary prevention. What is false about subdural hematoma?
B.
There are no lateralizing signs. In subarachnoid hemorrhage, do you find any lateralizing signs or seizures or any such feature?
No.
No. Unless there is a vasospasm. When will vasospasm occur in subarachnoid hemorrhage? If you don't hydrate the patient well, if you don't give calcium channel blockers. So what are the two most important things in management of subarachnoid hemorrhage? Hydrate the patient and give calcium channel blockers is what you need to remember. Now, yeah, Huntington's chorea, what is except?
D.
Beautiful question.
D. D.
B.
D you want to say?
D.
B. B.
B is the proposal coming from our Venkatesh. Any other?
D.
D for doctor.
Yes.
Huh? Chorioetitosis you want to say? Excellent. Basically, etitosis can proceed, it can follow, or it can occur at the same time as the mental symptoms. That is the speciality of Huntington's, is what need to be remembered. Typically, what are the iron granulations in RBC inclusions?
Papenheimer bodies.
Excellent. Papenheimer are those typical finding. Then multiple myeloma, what is except?
D.
You want to say?
D.
That means monoclonal antibody doesn't establish diagnosis?
It alone won't establish. Apart from that, clinical feature should be there.
Excellent. So it is a minimal criteria, not the major criteria. In order to, it is only used for screening, not for confirming the diagnosis. Then ADPKD,
D.
Autosomal dominant.
it is a autosomal
D.
dominant but not recessive. Good. Normal complement is the rule in
IgA
IgA.
nephropathy.
IgA nephropathy. All other are associated with hypocomplementemia. You have the high yield topic list now. Check pathology. Check pathology. What is the most high yield topic very frequently asked by frequency wise of all the topics? Because when you open Robbins pathology, it is a jungle. You must know what to read first and run out of that jungle. Yeah, what is the answer? What is the glomerulonephritis? Pathology open करते ही आप पहला पढ़ने का टॉपिक होता है glomerulonephritis. Next is inflammation, inflammatory mediators, blah blah blah. Number 3, amyloidosis. If you have ambition to read entire pathology, better do MD pathology. But if you want to top entrance exam, read the top 30 topics which I am giving to you in the list. The 5 questions in pathology in state entrance and 20 questions in all India come from the top 30-35 topics. Bas, must. Easy no? I am telling you, read less, play more, get a good seat. That is called as attending coaching with onlinemmbbs.com. Ideally, any teacher's job is that. A teacher who want to teach more is the most scary teacher in our life. Who teaches less and give you more playing time is the best teacher, and I love to be that. So then doctor, CMV, What is except about it?
D.
B.
Excellent. Acalculous cholecystitis, pancreatitis, everything is a part of CMV. In HIV, what is except? Beautiful question. Huh?
D. I thought.
MAC, MY. You mean
MAC mostly
MY.
causes respiratory infection, no sir.
Any alternative answer? D. Venkatesh?
C.
C. Anything else? Give a big clap to our last bencher. Loud clap, loud clap. What's the name, doctor? What's the name? You are telling very lighter voice. Gautam, that's good. I am very happy. Cryptosporidium. It is the same Gautam who gets in top 10? No, okay, no problem. Then, because healthy patients also develop acute infection with Cryptosporidium, immunocompromised is not required to get Cryptosporidium. So that's a main point to appreciate. Which will not lead to paradoxical splitting duct?
B.
Huh?
Right bundle branch.
Bundle branch.
Excellent. Right bundle branch block will delay the pulmonic component. So aortic comes jaldi, pulmonic comes piche. So widening will occur, not reversed splitting. Left bundle branch block mein P2 will come, and then in spite of P2 coming, A2 has not yet happened because the LBBB. So reversed splitting, paradoxical splitting will occur. Then Sjogren's, what is except?
D. Immune complex mediated.
Super. It is not immune complex mediated. Why is this important for us as a clinician tomorrow? Sjogren's is the most flirtatious disease. It can flirt with rheumatoid arthritis, you can get Sjogren's. It can flirt with SLE plus Sjogren's can come together. It can come with any other connective tissue disorder. Now you have a patient who has lupus and also Sjogren's. She found to have high creatinine and